bacterial, fungal, parasitic, and in fact, in non-infective, we have specific cellulitis and non-specific cellulitis. Coming to the infective orbital cellulitis specifically, it's more common in pediatric age group, and we do have the classification depending upon the clinical presentation of severity from preseptal cellulitis, orbital cellulitis, and cavernous sinus thrombosis, and in fact, they can be intracranial extension in these situations, and mostly they are preceded by sinusitis in children. This is a 27-day-old male baby, progressive swelling of the left eye, history of fever, no history of trauma. Now, what do you do? Of course, we go and do the imaging. As you can see in the imaging, in the medial aspect of the orbit, you can see an abscess. Now, the question is whether you observe, do conservative management, or you drain it. Well, I decided to go and drain it. First and foremost, to release, the compression of the globe and the nerve, especially because it's in the medial orbit. The nerve is very proximal to the medial wall of the orbit. And of course, I wanted to know the microbiological profiling. And this came out to be a methicillin-resistant Staph aureus. And this is what we do. We send for culture, blood agar, chocolate agar, and anaerobic culture in all patients. So, the child was treated henceforth with antibiotic and also a combination of dexamethasone with a smiling baby that you can see over here. So why is orbital cellulitis very, very important? It's of course an emergency. It can be vision and life threatening. And what are the things that can go wrong? You can have vision loss, cavernous sinus thrombosis, and intracranial spread. In this young adult, as you can see here, he has a subperiosteal abscess in the roof of the orbit. So only thing that I did was to go inside and drain the abscess, and he was absolutely fine to attend his engineering exam after the procedure. Case 2 is a very interesting case where this child presented 8-year-old girl with headache, eyelid drooping, and redness. As you can see here, she has a frozen orbit presenting with orbital cellulitis, where the father has given a history of a chicken pox, and the best corrected visual acuity in the left eye was no PL when she presented to us. So in this case, it was emergency. She was seen at 2 p.m. We took her into the OR, 4 hours later, and as you can see here, she has a muscle abscess. This is a lateral rectus muscle abscess with orbital apex syndrome and optic neuritis. Again, I went ahead, anterior segment approach, went and released the pus in the lateral rectus muscle. She was started with systemic antibiotics and intravenous methylprednisolone. Of course, her vision improved, and this was a timely intervention in this particular child. So, bacterial cellulitis, it's common, but we do see fungal granulomas in kids as well. This was a recurrent preseptal cellulitis in a child, which came out to be a filamentous fungi, and again treated with posaconazole. And it came from the sinus. You can see the sinus is involved. So the key distinction between an inflammation which is infective is that, you have to differentiate between preseptal and orbital. Orbital, pain with eye movement, proptosis, diplopia, reduction in vision. And when you have these red flags, imaging is mandatory, even when you find that it's a progressive preseptal cellulitis. Treatment, abscess drainage, I believe in that. Microbiology profiling and steroids is something that I add because we have very, very vital structures in the orbit. 20-year-old student, best corrected visual acuity was 6/60 in the left eye. It looks like an orbital cellulitis, but if you see the imaging, it's purely a dacryoadenitis, which is compressing the globe. The orbit is not much involved, but the entire lacrimal gland, in fact bilateral, but it was more on the left side. May 2018, I just started her conservatively with intravenous methylprednisolone. August 2018, after 8 months, she recurred, and when I did the imaging again, she had a bony erosion, as you can see in the superior wall over there. Well, that's not a good news in this situation. I went and did a biopsy, where I did not do a biopsy initially, and then it came out to be a sclerosing variant of IOID with vasculitis. Well, she was not responding to steroids alone. We did evaluate for tuberculosis, and the consensus was to start her on ATT, and she has never recurred henceforth. Case 5 came during the COVID times. As you can see here, painful orbital cellulitis in an elderly gentleman whose blood sugar was almost 450 milligram per deciliter, and suspecting a mucormycosis, because we had a pandemic of mucormycosis. Well, it was not fitting well in position because the sinus is absolutely clear, and I was not convinced. I went and did a biopsy, and this came out to be a natural killer T-cell lymphoma, and in fact, he died because of the disease. So, role of biopsy in adults presenting with orbital cellulitis is very, very important, because 30 to 40% of biopsied inflammations are associated with specific disorders. Case 6, 50-year-old gentleman. I thought this could be a lymphoma. As you can see, a salmon-colored patch in the conjunctiva. But this is an extensive involvement of the orbit, diffuse involvement with the lesion involving the inferior lateral and the medial orbit. Well, I went and did a biopsy, and this showed a storiform pattern, which is very, very classical of an IgG4 disease. IgG4 plasma was high, as in this particular case. So, although it was simulating malignancy or a neoplasia, it turned out to be an inflammation. So, orbital IgG4 related disease, there is a lot that we talk about it, and we have immense literature on the same. There is diagnostic criteria of this. I'm not going into the details because of the paucity of time. So, we treat all these orbital inflammation to start with steroids, and if it's non-responsive, you go for biopsy and other immunosuppressants depending upon the clinical diagnosis and histopathological diagnosis. So we have the first-line treatment modality, as I told you, steroid, second-line treatment modality. These are the preferable drugs that we have, and also biological agents are considered as a third-line modality. Rituximab really plays a role in orbital inflammation, whether it's specific or non-specific. The only challenge as an orbital surgeon and orbital specialist that we face is the recurrence of these inflammations. So this patient had multiple recurrence, and finally he settled with rituximab and mycophenolate mofetil. So can I just have two more slides to go here? So the key takeaway is early diagnosis saves vision in orbital cellulitis, be it infective or non-infective. You assume the worst because the vital structures in the orbit is so very important, including the nerve and the muscles. So always distinguish between infective and inflammatory. And surgical intervention is important as a treatment and to get an accurate diagnosis. Thank you so very much for your patient listening.
Thank you, Dr. Fairooz. I think we have time for discussion. Is there any question from the audience or?
Yes, hi. I can hear you very well, yes. Yeah, maybe not the audience.
If you are suspecting infectious orbital cellulitis,
Yes.
and for some reason you are not able to drain or get to OR very early,
Yeah.
so what would be your approach regarding antibiotics, whether in children or in adults?
In adults. So my preference would be a broad spectrum antibiotic because I don't have the microbiological profile. I would wait for 48 hours, and within 48 hours, if there is still, no regression and there is progression, I would go ahead and take a biopsy. Yeah.
So, Fairooz, just to put things into clear perspectives, because, there have been some publications about the conservative management of orbital cellulitis, which
Yeah.
I find it a bit weird to know that there is an abscess and we don't drain it.
Yeah.
So, the firm rule is if you have an orbital abscess, you have to drain, right?
Yes.
This is a very solid rule.
Very solid
And
rule,
I
yeah.
don't think it's as difficult as you think it is, because if you go to the point of maximum inflammatory response, maximum bulge, and you snip it with a knife and you go with an artery and you open, you drain the pus. So this will alleviate like 80 to 90% of the symptoms and the complications coming from the pus in a very close space. And we are solid about that, right?
100%. I agree.
So
100%.
if you don't have this, or if there is some delay for anesthesia purposes, or the kid or the adult is not ready, and they will take 2 days to get the operation room ready. So it's the coverage of antibiotic until you do the drainage. I just need this to be clear for all of us, because we have people tend to be sometimes conservative, people tend to be more aggressive, but this is the roadmap for orbital cellulitis. Preseptal is a totally different aspect of the disease as well.
Totally agree, Dr. Ihab. Any questions for me? Thank you.
Yeah. I have a question for Dr. Raza. Yes, Ganga.
Just a quick comment. I think you're right. But when the child is not fit for general anesthesia, then your hands are tied, right? So what you can do is actually you can use a 16 gauge or
Yeah.
14 gauge needle, which is available from your cricothyrotomy sets or IV cannulas. If you have a pediatrician who can give you some form of mild sedation, if you know your orbital anatomy very well and very good at
Yes.
orbital blocks, which we all are,
Yeah.
you can actually stick your needle in.
Yeah.
It can aspirate a significant amount of pus, which causes a rapid decompression while you continue and optimize the child for surgery.
Exactly.
It
Dr.
works
Gang-
for both for abscesses and acute hematomas of the orbit.
And post-operative seromas as well. You know, whenever you have, you
Yeah.
just remove a big mass from the orbit, and you find the second or third day that there is some collection, the ocular motility is not that good. You know, the body oozes fluid within the dead space that was created. So, you know, repeated aspiration even is very much into faster healing in those instances.
Absolutely.
Like Ganga said, you know.
I would like to add something here. If it is an abscess and if it's a child is young and very not able to go for a GA, we call it as a vocal anesthesia. Still, we actually inject a needle and just aspirate. So there is a decompression of it's not general anesthesia or local; it's vocal anesthesia.
Don't force
Thank
it on a child.
Yeah.
That's the wrong thing to do. And you have to be 100% sure it's fluid and not a tumor.
Right,
Definitely.
exactly.
I have
Thank you.
another question for you guys. Do we wash with betadine? You know, whenever you find an abscess coming and then you just keep washing and draining. At the end of the day, you know, whenever you have a near, you know, inflamed but clean, what seems to be clean, because we would know that there is a possibility of reaccumulation.
Mhm.
So the thing is there any role for gramycin, betadine to be washed in? And do you leave it drain or not? Because this is also, I think, an important question.
Very good question, actually. So betadine is considered to be the most, effective antimicrobiological agent. I definitely give a wash after the drainage, but I don't put a drain inside.
5%?
Yes. I don't put a drain inside, but I definitely wash with betadine. Yes. Thank you.
I mean, the primary source of an abscess actually is a paranasal sinus. So really draining an abscess, yes, there is some contamination over here. But if you're not taking care of the paranasal sinus part, I'm not sure what local betadine does. But you're right, the drain is important. The challenge will be, again, depending on where you made the incision. If it's upper lip crease incision, sticking a drain through and causing delayed healing, scarring, and so on and so forth. You can then go through the conjunctiva, which may be better. But whenever you can, if the vision is not threatened, it's not an acute compartment syndrome, 24, 48 hours of antibiotics, like all of you have said,
They do well. Yeah.
will consolidate the abscess before you drain it.
Yeah, I have a question for Dr. Raza. It's
Thank
a very nice case series, sir. I would just add to this the acute bleeding in lymphangiomas to your series and the inflammatory process, whether infective or non-infective, as a cause of acute or rapidly progressive proptosis. My question to you is, you know, the rhabdomyosarcoma is a serious cancer, you know, and also the malignant lymphomas are as well. And you also know that the chemotherapy is more effective when we have debulked the mass. So if you have your intention of having only an incisional biopsy, why have you gone through a subciliary large incision? And then when you had the diagnosis confirmed for the rhabdomyosarcoma case, why didn't you go back for a massive debulking, non-mutilating debulking, to ease up and prevent recurrences? You know, this is I think the standard of care.
Sub-brow incision.
Yeah, that's a significantly large subbrow incision, right?
What do you want? Because we have to give an incision directly at the tumor site to prevent seeding of the surgical tract.
No. I'm saying that you have a good exposure to debulk the tumor, the whole mass, you know, by the subbrow incision. So why did you go for a small, tiny bit?
Like going posterior to the orbit. We did I've just shown an incisional biopsy, but we did some debulking. But as we know, the rhabdomyosarcomas are quite sensitive to chemo and radiotherapy. So,
Yeah, but
and you have seen the result. It has responded very well.
I would have approached different, because, you know, I would have debulked, and then because here the staging is gross residual. You left gross residual, and the idea of chemotherapy, the smaller the mass it works on, the more efficient it is. But
it is very well localized. You saw it's not localized, not capsulated, not easy to remove all of the mass. can lead to the other injuries to the other part of the organ.
Okay.
And since the tumor, as you know, is quite chemosensitive and radiosensitive. So
Yeah.
this is our protocol. Yeah.
Glad for the patient. Thank you.
I want to ask you yourself. You are keeping asking me. What about bleomycin? Do you think we should really be doing it as oculoplastic surgeon ourselves, not delivering to others?
You know, as I mentioned, there is room for cooperation with the neuroradiologist. There are some intervention done by the neuroradiologist alone, those involving the brain, vascular drainage or vascular supply of the eye. So these are the best. They do it, you know, for the CCF, whether low flow or high flow. In the high flow, they use histoacryl. In the low flow, they use bleomycin. And there are also in cooperation. So if you have, like the lady I've shown, and this is extreme, I know, very large sinusoidal spaces in the orbit, and then you have to do surgery, they're quite helpful in preparing your patient for surgery. Because you cannot imagine the very large sinusoidal veins, and it's scary, you know, and you really have to tie them over and over while dissecting, and the risk of bleeding here is tremendous. So they help you in occluding the vessels so that you will go with a kind of a colder surgery while doing exentration. The neuroradiologists do not have access to an intraconal space. They wouldn't know how to approach it, even 2 to 3 days maximum, because the high flow fistula they will reopen. We did it the second day, and he had to do it over two sessions because he ran out of sclerosing agent in a center that is equipped for that, and it was huge. And you could see that the feeders are very, very tiny. This patient was treated in 2016, and I saw her last month. And we did her another arteriography, and there was tiny opening of the spaces, and he injected them back. I did not operate back. So, and there is room, as I said, you know, we can do on our own in highly vascular lesion that are intraconal, that has multicystic appearances, and whether we do it or we do it in a collaboration or they do it. So the room is really vast for that.
Dr. Mahmood, can I just make a comment? This is regarding the venous malformation and venolymphatic malformation and the application of bleomycin. So amazing surgery. So we go a little bit more microinvasive in my practice. We don't operate at all, you know, after recognizing the location of the lesion. It's mainly, and we go through the skin with the injection, no surgery at all. Totally microinvasive, go with the needle. And we usually use as a technique a 3-valve, aspirating syringe. Yeah. So one side it will be aspiration, it's a 3-valve, and the other side we inject. So we're going into...
What's your guide, Fairooz? What's your guide? An ultrasound guided, a CT guided?
Initially, there will be an imaging, MRI or CT scan. And if required, if it's very superficial, I don't do an ultrasound intra-op. But if it's deeper and I'm not really sure about it, I would do an ultrasound intra-op. Yeah, we have the always a standby ultrasound.
Okay. I think we have to conclude the session. Yeah, they need to start the next session. حاضر يا شيخ أنتم موري فندم بس كده. Thank you very much for being there, and inshallah see you next year. Yeah, we can you join for a group photo, guys? Just
Good afternoon. I would like to welcome all of you for the last session of the day and also last session of the meeting. Now we have I will call this hot topics in pediatric ophthalmology, and today we have very distinguished speakers that I'm sure that you will enjoy and you will learn many things from them. And in this session, our first speaker will be Arif Khan.